The topic which was asked to talk on today was on LV Summit VT. Of different electrophysiological changes, the anatomical have been shared with a couple of my colleagues, Dr. Santanjali and Dr. Hello? Hello? Hello, can everyone hear me?
Yeah, I can hear you.
All right. So when we talk about the ablation of LV summit area, the few things which we'll like to cover will be anatomical definition, the electrocardiographic characteristics, the anatomical relationship of different structures.
Your slides.
Yes, Rohit?
Slides are not visible. Your slides.
Slides are not visible.
Yeah.
So, do you mind resharing your slides?
All right, yes. I'm not sure what happened here. Can everyone see my slides?
So,
all right.
Yeah, now we can.
Sorry, let's start again. Good afternoon, everyone. I'm Rajeev, Pathak. The topic for discussion today is LV Summit VT ablation, and we'll try and cover a few things in this. The most important being anatomical definition of this area, the electrocardiographic characteristics or ECG changes we see. To understand and to be able to successfully ablate, it's important to understand the anatomical relationship of different adjacent structures around this LV summit area. We'll then discuss about how to elegantly map for PVCs coming in this area. And finally, how can we successfully try and ablate PVCs from this area? So the most important is the definition itself. When we're talking about the LV summit area, this is the highest point of the left ventricle. I mean, we're talking about the area which is the highest, or if you look at the anatomy, this is the topmost part of the left ventricle. I'll go into more detail when we go into the anatomical relationship, and we'll be talking more details about that. We then talk about the ECG characteristics of the PVC which comes from this area. The more pathognomonic changes, what we normally see, that these PVCs will be inferiorly directed, will be positive in lead 2, 3, and AVF. And most importantly, it will be more positive in 3 than 2, suggestive of it's coming not from right ventricle, it's coming more towards the left ventricle itself. We then look at the ECGs in AVL and AVR, and generally speaking, AVL will be more negative than AVR in these cases. Rarely you will see positive. Most cases, you see a pure negative in lead 1. Precordial transition can be right bundle branch block with no transition, or can be left bundle branch block within very early transition. It is possible that you might see pattern break in lead V2. So you'll see some R wave small R wave, then suddenly you have a large R wave and a small R wave, a pattern break, which is characteristic of PVCs coming from these LV summit areas. So these are the ECG changes we'll look into. When we look at the ECG changes to decide whether the spot where we're going to do an ablation is going to be successful or not, Pasquale Santanjali from Penn did this elegant work and looked at different PVC coming from this area to decide if ablation is going to be successful or not. And there are 3 ECG characteristic features which he looked into. Number 1 was looking at AVL and AVR ratio, essentially telling that if its AVL is more negative than AVR, then basically the site of origin is more leftward. And in those cases, it is possible to successfully ablate. It'll make more sense once we go to the anatomical relationship, but those are the ECG changes we talk about. Similarly, presence of R wave in V1 or initial Q wave in V1 are also a determinant of successful versus not successful. If you have a presence of R wave in V1, generally less likely to be successful, whereas initial Q wave, again, is a adverse predictor of ablation outcome in these cases. So let's look at this diagram, which will help us to understand this. So LV summit area is basically an area which is marked on the top by by the left main, and we are talking about this area between the LAD and circumflex. And so there are two areas which we can divide, and basically that's divided by the great cardiac and AIV vein. So we have an area which is unsuccessful ablation or not mappable, and the other area which we will be able to. So as we move more leftward, we get more AVL negative in comparison to the cases where the PVCs are originating from more rightward. In that case, AVR is more negative. So if you have AVL more negative, those cases you'll be able to successfully ablate because you'll be away from left main and LAD, whereas if it's AVR more negative, then it'll be less likely. So now, moving forward, let's discuss about the anatomical landmarks or the structures which are normally present around this LV summit area. So as I told you, this is an area which is bounded by the bifurcation of left main, LAD, circumflex, and diagonal. And it's really laterally transected by the great cardiac vein or anterior-interventricular vein. Basically, that transection itself can divide the area between unsafe area and safe area for catheter ablation. And the ECG changes we were talking about is AVL being more negative in this region if PVC is coming from, and AVR is more negative if it's coming from this region, marking and telling us that it's less likely we'll be able to do the ablation. So other important structures which are around there, which help us, as we were talking about, is anterior-interventricular vein and great cardiac vein. It's really important to understand, while we all think that, if I go back to that picture, normally we see and we think that it is almost running parallel to LAD and it's transect this area, this can be highly variable. So this elegant work way back in 2004 has shown that the relationship between great cardiac vein and anterior-interventricular vein, along with the coronary arteries, can be highly variable. And that's what we see here in this picture. So let's go through the living anatomy of these cases as we see. This is the case where basically we have found the PVC, mapping the PVC, and what we have done is put an agilis into the anterior-interventricular vein, and we are into the LV in RV trying to understand the relationship. And I'll go more into detail with this picture, which will help us to understand. So we are talking about PVCs which are coming from these areas. Okay, so when we talk about that, there are multiple different areas through which we will be able to access this. It can be left ventricle, and we go into the left ventricle, into the LV upper part of the septum. It can be from the left coronary cusp itself, or it could be the right ventricle from the side 3 of the right ventricle, extremely anterior part of the right ventricle. Now, those are easy targets if it is endocardial. But if it is an epicardial or mid-myocardial origin, site of origin, often in those cases, you may have to go epicardial. Now, if you go epicardial, then question comes whether this is really close to the left main and LAD, or it's coming slightly more lateral to it, and whether we'll be able to do a successful ablation or not in these cases. So this is the area we are talking about. So these are the multiple adjacent structures when we talk about. So whether it is epicardium, when we go through the veins, or we're going to go through the LV endocardium, or from the left coronary cusp to try and access this area. So let's look at these different areas and what are the ECGs. So this is a case where we put catheters into multiple locations, trying to map this PVC. And what we found is that this area, when we went into this interventricular vein, this beautiful signal which can be seen, which was way early, suggesting that this was deep, myocardial, more towards the apical area where this PVC was exiting for. As you can classically see, this PVC in these cases are right bundle, no transition, inferiorly directed with almost negative in lead 1, suggestive of coming from this LVOT on the top part of the LV summit area. Now, the most important problem when we are trying to do an ablation in the epicardium is the presence of coronary arteries. The proximity of the coronary artery makes it difficult for us to be able to do the ablation. So in this particular case, as you can see, it's almost impossible to do the burn. All the diagonals and perforators you can see are almost always, there. And of course, in this particular case, we were not able to do ablation from the coronary sinus itself. So then comes question, cases where we will be able to do an ablation. Now, in this particular case, again, the best view to be able to appreciate the bifurcation, we normally use a spider view, and you'll be able to see the, with the LAD and circumflex, and see whether you'll be able to do an ablation lesion. Anything after 10 to 13 millimeter away, it is okay to be able to burn. Anything closer, it may be difficult to burn. So that's what we talk about with the anatomy. We have done that already. We've discussed this, and we normally go often and do the pace map in this region. So we have discussed this part already. Now, when we are doing this ablation, it's extremely important, as we discussed from the anatomical relationship perspective, that we go and map in the adjacent areas. So starting the case, it's important to map in the left coronary cusp, map from the right side, map from the LV ostium, and also put a catheter in the coronary sinus to be able to map and find where the earliest spot is. In this particular case, we found in the left coronary cusp, it was the earliest. And a successful ablation in this site was performed, and coronary sinus was not early. As you can see, the earliest spot was in the left coronary cusp itself. Whereas there are other cases where you'll see that it is not the left coronary cusp, it is actually below the left coronary cusp into the LV summit, in the LV endocardium, where the spot was earliest. And in those cases, ablation should be performed in the LV. So that's why it's extremely important to really map that all the adjacent structures really carefully from the coronary sinus, left coronary cusp, LV ostium, and also from the right side. And use of intracardiac echo in these cases are extremely useful to be able to localize and understand the anatomical relationship and also see the catheter location. Now, we can do an ablation of this from RV side, as I was talking about. And in fact, there are cases where it is, you will have to do ablation both from right and the left side to be able to sandwich the spot where it's coming from, because it might be coming from deep intramural region. And in this case, we had to do a simultaneous unipolar ablation to be able to try and sandwich that area from both the sides. And that's how we successfully managed to eliminate the PVC. So use of intracardiac echo is extremely important in these cases. As we talked about, what we do is we look at the catheter, how far the left coronary artery is, and LAD, and gives us an appreciation of proximity to the coronary arteries, and to decide whether it's possible to successfully ablate these cases. So this is the case where we had to sandwich really from both the side. We ablated most anterior side of RVOT and also on the LV summit, and ablation lesions were almost applied on both sides to be able to do that. This intracardiac echo really shows an interesting image to see how close the left atrial appendage comes to this area as well. And, people have tried to do an ablation there. However, trying to ablate that deep into the left atrial appendage can be dangerous and can cause perforation. So I'm not suggesting that that's something which should be done routinely. So as we discussed, mapping from all the different spots from RVOT, LVOT, and entry into ventricular vein will be something important. What we normally do, we create a 3D map. We will have, we use Carto system, and we have a Carto Seg software. Using a Carto a CT scan of the heart, we segment the different structure. We understand the coronary arteries and its relationship, and we know this is the right ventricle, left ventricle, and this is the coronary sinus. We superimpose that so that we can appreciate the anatomy and understanding. And if we say that the PVC is coming from this area, we understand all the different diagonals and the branches. Sometimes actually branches may be difficult, but you will be able to appreciate the main coronary arteries. And if you are really worried about the diagonals, you need to do an angiogram at the time of the ablation itself to be able to make sure that you are away from it. But in this particular case, we found the earliest activation was in the coronary sinus itself, and a successful ablation lesion was performed. Sometimes you will have to map into the venous septal perforator, and this is Fermin Garcia from Penn used to do this very frequently, where he will put the either a Agilis and put a vision wire, which is a biotronic unipolar wire, into some of these septal perforators and do the mapping to understand the relationship of the earliest spot into how deep into the endocardium or mid-myocardium it is, and then to be able to successfully ablate or make an ablation strategy, whether the ablation should be performed primarily from the LV, RV, sandwich from both areas, or an ablation from all the adjacent structures have to be done to be able to eliminate this PVC. So this was the other case where we did it, and this is what shows where we went into the coronary sinus, and we found this beautiful early potential, and one lesion was delivered with complete elimination of the PVC. It's extremely important that we look into the contact when we are doing these ablations though. So different strategies which we use to try and get a good contact. And number one, which is extremely important, will be using a force sensing catheter. I would suggest using a contact force and force sensing and directionality, because as you can see in this particular case, we knew that the ablation lesions were performed towards the endocardium, rather than trying to ablate with no understanding whether the force is applied towards the left main or the coronary artery. This will help us to be able to understand the direction of the force being applied onto the endocardium itself. And the second, if you are ablating into, the LV, so if you're ablating into the LV endocardium itself, we sometimes use a long SL1 sheath, which will help us to be able to sit at the aorta or just below, and then use an ablation catheter to hook into the LV summit in ostium region and to be able to provide a good contact. I personally very rarely have to use this. I have used a Smart Touch DF catheter and use a D curve with a C shape, and we pull the catheter to be able to get sufficient contact. However, if you have less than 10 gram or 15 gram force, ablation in this area may not be successful. So I will recommend either using the catheter to make sure that you have a force, or use a long SL1 sheath to be able to achieve that good contact in that particular area. So this is exactly the case I was talking about. And finally, there are other various techniques which can be utilized. We used to use simultaneous unipolar, where we have two generators and we are using two ablation catheters, and one will work as a sink or a source, and the energy can be delivered in the intramural in this area. There are other studies where they have used the patch and trying to change the position of the patch to be able to try and direct the current in the drain, and to direct the current towards the spot or area where you want to ablate. And finally, bipolar ablations can be performed in these areas. Again, they're useful, should be done with have to be careful because of the risk of complications which are possible. But use of intracardiac echo is extremely important in these cases to be able to see the spot where you're ablating, make sure that you have a good catheter contact when you're doing the ablation. So in summary, ladies and gentlemen, LV summit is the highest point of left ventricle. Epicardium bounded by the LED bifurcation and crossed by the venous system. Understanding of this anatomy is extremely important. The origin is probably intramural into that thick part of left ventricle, and therefore ablation can be challenging. Diligent mapping rather in different adjacent areas is extremely important. And ablation either at the earliest spot or at multiple adjacent spots may be necessary for a successful catheter ablation of these areas. Left atrial appendage and epicardium usually not helpful, as we discussed, because left atrial appendage, while it is anatomically very close to that area of our interest, ablation that deep into left atrial appendage is almost extremely difficult unless there have been a couple of crazy cases where people have gone and perforated through left atrial appendage to do an ablation. I will definitely not recommend that. Epicardium is not necessary. In fact, you will not be able to ablate because of the presence of fat. If you need to get epicardial access, it'll be coronary sinus, go into the coronary sinus, reach that spot and do an ablation there. And really important, good contact using a force sensing, direction sensing catheter is important. Use of high power and prolonged lesion sometimes may be necessary if you're especially ablating from the LV endocardium, because you are really trying to go deep into the muscle to be able to try and eliminate this. At this point, I'm going to stop. I'm happy to take any questions. Thank you very much.
Thank you, Rajeev. I think the topic was very well covered. There were beautiful cases and very wonderfully done, the ablations. Yeah, it was a very informative lecture.
Thank you.
So we are grateful to Rajeev for sharing his knowledge and expertise with us, so we can see how the cases and the expertise and how beautifully it was done and successfully it was done, and also he has given his approach in a very simplified way when to do this ablation, how to do this ablation, how to what are the tips and tricks for doing this case, and when to avoid and when not to indulge in heroic things in this area.
That's
Because
exactly right.
if you ablate the left main or do some perforate the left atrial appendage, sometimes the arrhythmias might not be so lethal, and you may end up having significant medical legal problems. So
that's exactly right.
This was a very well presented lecture. We are thankful to Rajeev, and we will keep on learning and inviting more for more interesting webinars and interesting cases. I think you have a lot of them. And,
thank you. I'm more than happy to get involved, right?
Yeah. So I think the COVID is also, maybe we will have more lenient travel conditions after a few months, and then we can plan some, I think, workshops with you, and Narendra is also waiting for his turn now. So thank you very much, Rajeev. It was a pleasure listening to you, and thank you very much. So
thank you. Hi, Narendra. I think
you can just be on panel for the next talk, which we are going to take up from Dr. Narendra. He's cardiac electrophysiologist from UK. He has done his MBBS from India, B.R. Ambedkar Medical College, Bangalore. After that, he moved to his training to UK, has been a scholar at Netherlands, and has pursued his clinical fellowship in cardiac electrophysiology from Maastricht University Medical Center, and he also is an European Heart Rhythm Association certified electrophysiologist. He also has multiple numerous publications and citations, and is actively involved in atrial fibrillation and ventricular arrhythmias, clinical and basic research. So he is also a visiting consultant who visits India frequently and conducts many workshops. He has been a regular feature of our conference also. And we are going to take up an interesting case of ET ablation with Dr. Narendra. So yeah, Dr. Narendra, over to you.
Are you able to see my screen now?
Yeah, we are able to see your screen, and like I forgot to tell that he also has like made an educational academy for this heart rhythm, his heartbeats, and he is very active in making electrophysiology courses and disseminate it to the young students in India.
Thank you so much, dear, for the wonderful introduction. If Dr. Pathak, can you hear me?
Yes, I can.
So
Right,
there was,
how are you?
yeah, fine. Thank you so much. May I have a quick question for you? So
Yes,
I'm a,
for sure.
so thank you so much for sharing from the wonderful, great treasure of knowledge, especially about the ventricular arrhythmias, which you shared. So I am aware that nowadays, as you shared as well in some of the slides, hybrid approach as well is getting popular. For example, trying to use dual catheters from the different sides to put it up to increase the transmurality and also the depth of the lesions as well. You already showed some of the techniques which you said it, which you try to modify and try to use it as well. Do you have any special recommendation for any kind of devices? Because a lot of those ablation lesions can be pretty superficial, and when we want to have a deeper lesion set, it can be a little bit difficult to achieve. Anything from your experience which you would like to suggest, please?
So there are multiple things which are currently available. I will tell you all of those different things which have been practiced. I'm not suggesting that this is something which everyone should do. I'm just going to tell you all the different things, because sometimes you worry, you tell these things and someone will start picking up and then start doing those things. So people should be very careful and use this only if they are in an experience center, they have done it, they've seen. So number one approach, and the most important, which everyone can do, catheter contact using a force sensing, direction sensing catheter. A good force, longer lesion in a safe area is okay to do.
Yeah.
And number two, simultaneous unipolar. Simultaneous unipolar is when you have two catheters in two different locations which are strategically selected so that you can give a lesion in the intramural region. You will need to have two basically set of ablation, the generator and everything, and two people will have to come on at the same time, and that's how you do it. The next one is a bipolar ablation. Of course, that's a technique which can be used. Number four is use of half normal saline, which is from Wendy Zhao's group from Denver. These group of people have mastered this, and they use the half normal saline to try and get a deeper penetration. That is a possibility. Then there are people who will go give an alcohol injection into the septal perforators. I have not done that. I'm not recommending. That's something which can be done. Then there are surgical approaches. A surgical approach in which one case which was done in Melbourne, where basically they opened the chest because all other different things they did failed. Patient was having LV dysfunction in a young person. Basically left main and LAD was moved up, ablation lesions were performed, and the vessels were then regrafted again. Now, it's an extreme approach which should only be done in a selective cases where almost everything has been exhausted. All those different things can be possible. There's a new catheter with a perforator or a needle catheter, which has been developed by Biosense Webster Group.
Right.
And Bill Stevenson, Professor Bill Stevenson is basically the person who has used it. I haven't personally used that catheter, but that's in Horizon as well. All of these different extreme measures come with their own risk and
Right.
risk of having complications. So these are the different things which are currently available.
No, great. Thank you so much for again sharing those practical things. In fact, there are some points when even at a lot of people, they even tend to give up, literally. Like they have tried, it doesn't disappear. So it's always good to have these tips and tricks in the baggages of those people who are dealing with such cases. Thank you again for